All right. Good evening, everybody. Thank you for coming. Tonight we'll be talking about shoulder pain. The official title of the talk here is Don't Shoulder the Pain, Common Shoulder Conditions in the Recreational Athlete. My name is Dr. Robert Pettit. I'm a sports medicine fellowship trained orthopedic surgeon with Beacon Orthopedics. Excited to talk to you about shoulder injuries and painful shoulders tonight. So a little bit about myself. I was born and raised in Cincinnati. I originally went to St. Xavier High School, and then did most of my training for undergraduate, as well as medical school and post-grad training up and down 71 in Columbus at Ohio State, University of Cincinnati, then back to Ohio State for residency training. I had the opportunity to move out to Boston for a year and do a sports medicine fellowship, learning from some of the experts in the field of sports medicine in Boston. Had a great opportunity there to work with the Boston Celtics and some of the other sports teams in the area. I then joined Beacon and have had an absolutely fantastic time helping treat athletes of all ages around the city with various high schools, collegiate level, as well as professional. So I came across this as I was making this PowerPoint, and it's a tweet from Joey Votto after his shoulder injury. He found out that he had a rotator cuff tear that ended his season last year and subsequently required surgery. He was in the midst of having one of his down years, so he wasn't hitting as well as he had in the past, and I thought it was somewhat comical. He tweeted, "I didn't know I was hurt. I thought I just stunk." My reason for putting this in here is just basically to mention that athletes of all ages and all levels can have injuries and pain. Sometimes it's good to play through it, but sometimes there can be something underlying. So hopefully we can encourage people to have it checked and get the appropriate treatment. So just an overview of the talk tonight. We'll plan on talking about the anatomy of the shoulder, which will help us understand some of the ailments that can plague people with shoulder pain. We'll also talk about some of the common causes of shoulder pain, some ways to prevent issues with the shoulder, talk about some important factors that can contribute to seeking medical attention, and then also what to expect during an orthopedic surgery consult. We'll talk about some of the most common conditions that I treat, the common treatment options, as well as going over some of the physical therapy exercises at the end with one of our all-star physical therapists here, Rob Mowry. So start things out with anatomy. So I'd like to talk about a few definitions just to get everybody acclimated. So some basic building blocks of joints and musculoskeletal care. Tendons are structures that connect muscle to bone. So they are the unit that help specifically for the shoulder, move the shoulder out in space. If a tendon is injured, it can lead to pain, stiffness, as well as weakness of the shoulder joint. Ligaments are involved in connecting bone to bone. Ligaments help contribute to stability. So if a ligament is injured, whether it's from a dislocation or another sort of injury, it can lead to instability, which can cause pain and dysfunction of the joint. And then cartilage is the soft tissue that covers the bone in joints and provides a smooth, pain-free surface for joints to function appropriately. The process of arthritis is the breakdown of cartilage, which can lead to dysfunction. So with that in mind, we'll move on to bony anatomy. The bony anatomy of the shoulder is really comprised of three bones. So you have the clavicle bone, which is highlighted here in green. The clavicle or the collarbone is in the front of the shoulder, as we all know, and that connects to part of the larger bone, the scapula, which has an area called the acromion. The reason this is important is it creates a joint at the top of the shoulder called the acromioclavicular joint, which is often injured in contact sports, but can also be a source of pain for recreational athletes and people of all activity levels. So the scapula also has a bone here called, or a portion of the bone called the glenoid, which is essentially the socket of the shoulder joint. and that connects to the top of the arm bone, or the humerus, which is right here. This is called the humeral head. So when we talk about the shoulder joint, we typically think of what's called the glenohumeral joint, and that's this joint right here. So that's the glenoid, or the socket, and then the humeral head. This picture kind of demonstrates that it's akin to kind of a golf ball that sits on a golf tee, mainly because it's a larger ball that sits on kind of a shallow and small area that it has to balance on. So that is very good for shoulder motion. However, there is a complex orchestra of muscles and biomechanics that goes into keeping the shoulder stable and also allowing it to function. Some other structures in the shoulder that necessitate talking about are the labrum. That's something that's often injured in younger athletes, specifically when they have an event that causes instability. The labrum is a cartilaginous ring that you see here that deepens the socket of the shoulder, and as I mentioned, gives stability. In patients that are over the age of 30, typically the labrum is less involved as a pain generator. Furthermore, the shoulder joint and all joints are lined by something called a capsule, and that essentially functions to give stability to the joint, but also holds in what's called synovial fluid, which bathes the joint with nutrients and also gives lubrication and compression to joints. No talk on shoulder would be complete without talking about the rotator cuff, which is one of the most commonly injured structures in the shoulder. Its function is very important. There are 4 muscles and subsequently 4 tendons that connect to the bone that help move the arm in space. So it helps move the arm up, out, behind, as well as away from the body. And there are rotator cuff tendons there's one in the front called the subscapularis, as you see this one here. The white portion, as you can see here, is the tendon. And then there are 3 other tendons. The most famous or most commonly described as the supraspinatus, which is on the top of the shoulder and attaches to the top of the humeral head here. And that helps lift the arm forward, or what we call forward flexion of the shoulder. Furthermore, the infraspinatus and the teres minor are more in the back, and they help to bring the arm into what's called external rotation. So that's away from your body. Typically, the rotator cuff, I think this picture demonstrates pretty well, the rotator cuff attaches to the side of the shoulder there, and that's why typically rotator cuff issues present with pain on the outside of the shoulder. Another tendon that's involved in the shoulder can often cause pain or symptoms is the biceps tendon. So the biceps muscle has 2 origins of tendons, one outside of the shoulder joint and one inside of the shoulder joint, as you see in this picture here. The one that attaches into the shoulder joint, called the long head of the biceps, has a pretty circuitous route from the shoulder. As you can see here, it bends about 90 degrees from where it starts at the labrum. And as that happens, it can be under a lot of tension and it can undergo a lot of strain as people undergo overhead activity and use that biceps tendon. Oftentimes patients have pain in the front of their shoulder in an area called the bicipital groove, which is this area here, which can oftentimes be a source of pain and dysfunction. So what are some of the causes of shoulder pain? So we mentioned all those structures, and those structures are typically the main pain generators in the shoulder joint. Some things that can happen to those structures, so you can have a strain. That is when a muscle or a tendon injury occurs. It can cause pain, inflammation, decreased strength, and decreased function. A sprain is a ligament injury, so that's the connection between bones, and that's when those get stretched, and those can cause instability of the joint as well as pain. Tendinopathy is a technical word that we use to basically describe tendons that are not healthy, but they're not torn. So this can happen typically as a result of aging or degeneration, but it doesn't necessarily mean that we have to intervene on it, but there is certainly some problems with the tendon. Tendinitis, another common term, itis meaning inflammation, so that's inflammation of the tendon. Again, that can happen from overwork or overuse, as well as aging. It can also cause pain, discomfort, dysfunction, and weakness. And then finally, arthritis, or loss of the articular cartilage that we talked about, can also cause symptoms as well. So prevention is key with many of these issues to keep people doing the activities that they love, whether it be racket sports, weightlifting, swimming, or just doing their daily activities. There are some key things that we can keep in mind. These preventative techniques are mainly geared towards patients that are doing, as we mentioned, overhead activities, swimming, weightlifting, and recreational sports. So the first is ease up. So activities that place a lot of stress on your tendons, whether it be all the things that we talked about before. Try not to do them for too long periods of time. And if you do experience pain, don't ignore the pain. Stop and rest and let your muscles and tendons recover. Cross training is also a good way to mix up the different types of exercises that you do. So doing the same exercise over and over, day in and day out, can certainly stress the tendons and the structures in the shoulder, which can lead to pain and dysfunction. And then improving the way you move. So if the activity that you're doing or the exercise that you're doing is not with the proper mechanics, that can set yourself up for tendon problems as well as pain, and so on and so forth. So oftentimes working with either a trainer or a physical therapist or a coach that can walk you through the biomechanics and the best way to do certain activities can certainly be helpful, especially as you start a new sport or new exercise. Stretching cannot be underemphasized. Stretching, especially after activities, can be very helpful to keep the full range of motion and to offload the joints. So warming up, but then also after the activity, stretching can be very helpful in preventing problems. And then just in day-to-day activity, whether it be in the workplace or when you're not doing recreational activities, making sure that your ergonomics are correct, such as when you're sitting at a chair or at a keyboard or a desktop, try to position yourself, have good posture, so that you're not straining your tendons and ligaments and joints day in and day out. And then if you are going to undergo a new activity, strengthening the muscles that you'll be using and stretching those out will hopefully prevent overloading of those muscles before you really get into certain activities. So general treatment strategies, if you do start having shoulder pain, the common things that we talk about are rest, ice, ibuprofen, or NSAIDs to help decrease inflammation. So those are typically the first line of things that any medical professional will mention, as long as you don't have any medical problems that would prohibit taking ibuprofen or NSAIDs. So that being said, if you try those things and still having pain or dysfunction or problems, how do you know when it's best to come see a physician or a medical professional for a consult? So typically, if you're doing an activity and you feel a pop immediately and have pain, that's a pretty good indicator. If you're not able to move your arm, and these are all going to sound pretty obvious, but it's at least worth mentioning. Not able to move the arm, extreme pain at the injury site, again, specifically an acute onset. If there's any swelling or bruising in the area, and then if there's a deformity, that could be indicative of a dislocation or even a fracture. And then if you have pain that has lasted for greater than 2 weeks despite doing those non-operative measures, then it's probably a good time to come see one of us at Beacon. All right, so what can you expect? So if you do decide to come in and have your shoulder evaluated, what can you expect? Well, typically, we'll sit down, we'll talk about any medical history. I'd be certainly interested in hearing about the mechanism of action or the kind of the history of how the joint pain or dysfunction started and any specific injuries that occurred. We would do a physical exam, which would entail checking the range of motion of the shoulder, as well as checking the strength of the shoulder, and doing some special tests to try to elicit symptoms. Further, some imaging. Typically, we'll do an X-ray on the first visit, and that helps to diagnose things such as arthritis or to rule out any issues with if there could be a fracture or any underlying issues with the bone. We'll typically provide then a diagnosis or a list of possible diagnoses, which is called a differential diagnosis, but sometimes further testing might be needed. And then finally, a treatment plan of how to get that shoulder better. And I'd like to spend a little bit of time on treatment plan and just mention that every patient is unique. So, not every rotator cuff or every case of arthritis or biceps injury is the same. I specifically like to collaborate with my patients and kind of develop a treatment plan based off of their goals, their specific needs and problems, and work together to make that. Typically, the least invasive options are first. Those, as you'll see a theme here, we'll mention several times: rest, ice, anti-inflammatories, physical therapy, exercises to strengthen the muscles. Injections are an option. Typically, we talk about steroid injections as something to decrease inflammation and to aid in the ability to work through physical therapy exercises. An MRI sometimes can be, or often is ordered if there's concern for significant tearing or if conservative measures are failing. And then finally, surgical options are discussed once all these other measures have been unsuccessful. So some common conditions, things that I see in the office pretty much every day: pain in the biceps, impingement, which we'll talk about more in depth, rotator cuff problems, arthritis, pain in the AC joint, as well as frozen shoulder. So starting with biceps pain. So as we mentioned before, the biceps travels up the front of the shoulder and into the shoulder joint. It typically arises with overhead movement and following repetitive motion, whether it be racket sports, swimming, or lifting weights, where overuse tends to cause tendonitis or tendinopathy in that tendon. Furthermore, there can sometimes be labral involvement, meaning the attachment site to the biceps can pull some of the labrum on there and cause significant pain with certain motions as well. So how do we treat this? Well, again, all the conservative management that we talked about: anti-inflammatories, rest, ice, and physical therapy. An ultrasound-guided steroid injection where we actually find the sheath and put it directly into that area can be very helpful. And if those all fail, there are surgical options specifically called a biceps tenodesis, which is effectively shortening the biceps tendon and reattaching it outside of the joint to effectively decrease, to remove the area that is inflamed and unhealthy. Subacromial impingement is a very common source of pain that we see. Typically, it happens, or it can be called bursitis, which is inflammation of the bursa. And what a bursa is, if you can see here, this blue area, it's a fat sac that pads bone from tendon. And it is there as a cushion, but in certain circumstances when the space in the subacromial area, or right underneath the bone here, the acromion gets constricted, the bursa can be inflamed and cause pain. It can also cause spurring, which oftentimes people talk about bone spurs, which can push on the rotator cuff or on the bone and cause pain and inflammation. Oftentimes, patients will complain of pain at night and oftentimes weakness overhead. So the people that get impingement syndrome, really anybody who's doing repetitive overhead activity: throwers, tennis players, swimmers, craftsmen. Here's some other pictures that show the bones impinging on each other when you start to lift your arm up. How do we treat this? Again, more of the same conservative treatments. This is something that we really try to avoid surgery with. So cortisone injections, sometimes even several, can be helpful. We really use physical therapy and rely on our therapists to rehab the shoulder and get the rotator cuff functioning appropriately. And as a last resort, arthroscopic decompression. So arthroscopic meaning minimally invasive surgery where small poke holes around the shoulder using a video camera, we go in and clean things out to help with that inflammation. So the rotator cuff, another very common source of pain and dysfunction in the shoulder. As far as patients over 40 years of age, if you were to get an MRI on, the majority of patients over the age of 40 would actually have some sort of tear, whether it be partial or full thickness tear of the rotator cuff. But interestingly, the majority of those patients are not symptomatic. And for that reason, we don't go treating every rotator cuff tear unless it is symptomatic. Again, how does this present? Oftentimes patients come in because they're having significant pain at night that wakes them up. Again, pain with overhead use, and then sometimes in large tears, there can be weakness or inability to lift the arm. There are kind of two different ways that this can happen. So the most common is with aging and overuse, where the tendon quality as we age, unfortunately, is not as good. And with repetitive motion, similar to getting a hole in your jeans, the cuff can be rubbed on and can form a tear or a hole in it. The other way that a rotator cuff tear can happen is if a patient falls onto an outstretched arm and has an instability event of the shoulder that causes the rotator cuff to tear. This slide is a little bit more intense than it needs to be, but the main reason for putting this in here is that not all rotator cuffs are created equal. So that means that there's different sizes of rotator cuff tears, so it can involve just part of one of the tendons, or it can involve several of the tendons. It can be full thickness or not full thickness, but one person that has a rotator cuff tear does not mean it's the same as another person that has a rotator cuff tear, and that goes back into the paradigm that we try to tailor treatment to each individual patient based off what they need. So treatment of rotator cuff tears, physical therapy, again, to restore range of motion and work on strengthening. Depending on the type of tear that is present, or if it's just a sick tendon, as tendinopathy that we mentioned, we often try to treat that conservatively with, or non-surgically, with anti-inflammatories and an injection. However, when tears are full thickness, we do know that these often can progress and get larger, which can lead to more significant dysfunction and pain, and therefore we often recommend surgery for full thickness tears. So the decision whether or not to do surgery in a patient that has a full thickness rotator cuff tear is complex and specific to every patient. However, the main considerations are how has the patient responded to non-surgical treatment, what is the age of the patient, what is the size of the tear, what medical problems does this patient have, and then what kind of help do they have at home to help get through the recovery, as the recovery is rather extensive. So we try to make sure that we talk to patients about that before jumping right into surgery. This is a picture that shows here a tear in the rotator cuff. So that's the white part here, tear right here, and then this is one of the techniques, one of many techniques to fix it. So we again do it arthroscopically, minimally invasive outpatient surgery, where we put sutures into the tendon, and then we bring those sutures across, bringing the tendon back down, and we hold it into the bone with something called suture anchors. Switching gears now to shoulder arthritis, another increasingly common source of shoulder pain, similar to arthritis that you can have in a hip or in a knee. The shoulder can also have arthritis. It's a little bit different considering that you're not walking on your shoulders like you are on a hip or knee, but it can still be significantly painful and cause a decrease in quality of life for patients. This typically presents with decreased motion. Oftentimes patients will tell me that they have trouble reaching behind their back, to tuck in the back of their shirt. That tends to be one of the first signs of shoulder arthritis. Oftentimes they will complain of pain deep in the joint, as well as catching and popping of the shoulder as they move it around, and then pain with movement as well. So the treatment for arthritis, again, more of the same theme with conservative measures first with anti-inflammatories. You really want to work to keep the range of motion in the shoulder, so home exercises and physical therapy come into play with that. In patients that are not bone-on-bone arthritis, so that still have some cartilage left, injections can be helpful, and even sometimes an arthroscopic surgery, which is a faster recovery, to clean the joint out and release some of the soft tissue to increase the range of motion and decrease pain. In severe cases of arthritis, a shoulder replacement often is an option. I tend to think of the most standard type as more of a resurfacing, where you are really just removing the part of the golf ball and the golf tee that has arthritis and putting a new surface on it in the form of a metal hemisphere as well as a plastic peg, as you see in this picture here. AC joint pain or acromioclavicular pain is another common source of pain. So if you've ever heard of a separated shoulder, someone falls directly onto their shoulder, or hockey players that get checked into the boards, they can strain the top of their shoulder here, the AC joint. Typically we treat that with a sling for a short period of time followed by physical therapy. But then you can also have arthritis in that joint as well. Very common in weightlifters. That often can be improved with injections and sometimes surgical debridement. Oftentimes this is accompanied by other problems, whether it be a rotator cuff tear or bursitis, and so we address all of those things at the same time if surgery is necessary. Finally, an entity called adhesive capsulitis or frozen shoulder. This is an entity that often is related to some sort of traumatic type event, whether it be jarring the shoulder or falling onto it. It's more common in females that are between 40 and 60 years of age and that have a history of thyroid disease or diabetes or some sort of other medical problem. However, it is fairly common and can happen to anyone. But it results in pain, and the hallmark of this is stiffness. So patients that really can't move their shoulder even when a physician or someone else is pushing on it is diagnostic for adhesive capsulitis or frozen shoulder. That tends to be a problem that's caused by a tight capsule, so that's the lining of the joint, and it gets adhered down and tight and restricts that motion. The mainstay of treatment is therapy, which can take several months. We try to help the process along with injections. Very, very rarely surgery is indicated to open up that capsule and maneuver the shoulder so that there's improved range of motion. So with that, that covers most of the things that I wanted to talk about. I'm happy to answer any questions if anybody has any questions right off the bat. Otherwise, I'll hand it over to Rob, who's going to demonstrate some physical therapy exercises for us.
Does any of that that you've described there affect the, I think it's the clavicle that runs down the back, and you have a lot, you can get very severe pain, and sometimes it'll go down her arm. And so typically the most common pain pattern that I'll see with a rotator cuff injury, for instance, is pain on the outside of the shoulder that can sometimes go all the way down to the elbow. If it goes past the elbow, then we start thinking of other diagnoses. It could be related to the neck or a pinched nerve. But yes, rotator cuff pain can radiate down to the elbow, typically on the outside of the shoulder. In that back of that clavicle.
In the back of the shoulder blade there?
Yeah, back of the shoulder blade.
Yeah.
And sometimes it does. It goes all the way down, and I'm just like, I broke my wrist, and you know that's one thing, and then it goes like my elbow, and you can feel it, and I'm like, you know, and if I lift anything heavy, it's horrible.
So one of the things that I'll talk to patients about in that sort of situation is talk to you about the quality of the pain, meaning what type of pain is it? Is it a burning type of pain? Is it an achy, stabbing type pain?
It's like a sharp pain. I mean, you can feel it, and I can feel it pull. And so I stay away from it, I let my son take it.
Yeah, especially if it's related to movement of the shoulder. It does sound like it could be something in the shoulder joint, whether it be arthritis or impingement or rotator cuff, but all of those things
Well,
could
I
help
fell,
explain
and
that.
that's when I fell, I hit my shoulder, I hit my, and I broke my wrist, and also, the elbows, I took too. And so I thought everything's fine, but every time I picked something up, it just hurt so bad. I can't lift anything heavy at all, I just can't do it, but my kids help me a lot, but it's just like, I'm tired of this pain.
I think you're one of the kind of ideal patients for this talk, because it sounds like you've kind of managed this for a period of time, and now you've kind of enough is enough. So,
That's about right.
yeah. So I think that there certainly in the office be some things that we could talk about and offer you to help alleviate some of that pain.
Okay, thank you.
You're welcome.
That's what we'll do.
Do you
Okay.
consider the rhomboid muscle groups to be kind of a part of the shoulder, or do you just look at that shoulder capsule itself?
I think that's a great question. I would consider it part of the shoulder girdle. So all the muscles, so the 17 muscles that attach to the scapula, as well as the SC joint, the AC joint, the glenohumeral joint, all of those structures, I think, contribute to the mechanics of the shoulder. And if the scapula is not moving, or the shoulder blade is not moving appropriately because of rhomboid dysfunction or other issues with those muscles, I think it can certainly have an impact on the health of the shoulder.
Do you ever do injections for that area, or do you just predominantly do physical therapy?
So physical therapy first. As far as trigger points are concerned, that can be an option. You can also get bursitis behind the shoulder blade, which can have some kind of grinding behind there, which sometimes an injection can be helpful for as well. But also pain in the rhomboids is another indicator of maybe looking into the cervical spine as well, into the neck, because sometimes you can have something called referred pain, which is pain that's coming from elsewhere, but it can be presenting in a different area. And specifically a nerve impingement on what we call the C5 nerve can go right to that area on the
I
rhomboids.
was thinking more of a thoracic descent for pain.
Yeah, there's a differential diagnosis for it, several things that it could be.
What's your phone number to make an appointment?
So I can certainly give you the phone number. I think it's on there, but it's 513-354-3700. But we can certainly work together to get you to, we can make it a little bit easier process to schedule for you afterwards if you like.
Do you need to do x-ray here?
Yeah,
Yes.
we have X-ray upstairs and PT upstairs.
I know
And the
PT,
physician's
yeah.
upstairs.
Yeah, yeah. We have a full service clinic upstairs, so we can do X-ray, we can do injections, and basically do a full assessment. We do not have MRI upstairs, but maybe eventually. But we do have MRI capabilities at other
Do you
locations.
require referrals?
No, no. Patients can schedule 24/7. So on our website, you can go to beaconortho.com and schedule same day. But then also you can call that number anytime. And we typically offer next day appointments without a referral. Any other questions? All right.